Okay, sir. Sure, sir. Okay, sir.
இப்போ மைக் ஆனா இருக்கா? ஒன்றும் கேட்கல.
Sir, yes, sir. Just a second, sir. I'll start, sir. Good evening, sir. Sir, the topic for today's discussion is weaning from prolonged mechanical ventilation, sir. Prolonged mechanical ventilation. And my second topic is on the golden hour, sir. So to start with the introduction, weaning refers to the process of gradual withdrawal of the ventilatory support. And the weaning success is going to be the absence of ventilatory support in at least for 48 hours after extubation. So there are several criteria, sir. So to start with the ventilatory criteria, the spontaneous breathing trial, the patient should tolerate for up to 20 to 30 minutes of spontaneous breathing trial, and the partial pressure of 50 millimeters of mercury with normal pH, and the pH should range between 7.35 and 7.45, and the spontaneous tidal volume should be more than 5 ml per kg. The respiratory rate should be less than 35 breaths per minute, and also the minute volume should be less than 10 liters per minute with appropriate ABG in these patients. The vital capacity should be more than 10 ml per kg. And the oxygenation criteria is going to be the partial pressure of oxygen should be without PEEP should be more than 60 millimeters of mercury at least the FiO2 of less than 40%. And the partial pressure of oxygen with PEEP should be which is less than the PEEP less than 8 centimeters of water should at least be more than 100 millimeters of mercury at an FiO2 of less than 40%. And the PaO to FaO2 ratio should be more than 150 millimeters of mercury, and also the saturation should be more than 90% with a FaO2 of less than 40%. And the AA gradient should be the AA gradient of oxygen should be less than 350 millimeters of mercury at an FaO2 of 100%. And the pulmonary reserve, the maximum voluntary ventilation should be twice the minute volume at an FaO2 of 40%. And the maximum inspiratory pressure should be more than negative 30 centimeters of water in at least 20 seconds. So there are indices which can also be used to assess whether the patient can be weaned off from a ventilator, which includes the simplified weaning index or crop index, or also an RSBA index. So the weaning parameter should be this is also called as the maximum inspiratory pressure, where the negative inspiratory force defined as the amount of negative pressure where when a person can generate in 20 seconds when the when he's inspiring against an occlude measuring device. So usually the normal values are around minus 120 centimeters of water in a healthy male and minus 90 centimeters of water in a healthy female, and also intubated patients the value should be minus 30 centimeters of water. The force vital capacity in normal patients, it should be around 70 to 80 ml per kg, and intubated patients should be 10 to 15 ml per kg should be sufficient for weaning. The risk factors for weaning failure includes the pathophysiological conditions where the patient might be having any infection, sepsis, or any renal failure. In the cardiovascular, the patient might have a hypertension or a hypertension. Maybe the patient is on a low cardiac output or arrhythmias. On the metabolic disturbances, including acid-base imbalances and dyselectrolytemias. The signs of the weaning failure include the early signs includes tachypnea, delirium, or diaphoresis, and any use of accessory muscles for respiration, and also chest abdomen and asynchrony. There will be a paradoxical abdominal movement seen in these patients. And in the blood gas, we can see a progressive hypercapnia, which can rise up to more than 50 millimeters of mercury, and progressive respiratory acidosis can also be seen, or a hypoxemia where the patient can go up, PaO2 can go less than 60 millimeters of mercury. And in the vital signs, there can be changes in the BP, whether 20 millimeters of mercury in systolic blood pressure or 10 millimeters of mercury from the diastolic blood pressure can be reduced. There can be a progressive tachycardia can be seen, which should be around more than 110 beats per minute, or some arrhythmias can also be seen. In the respiratory parameters, there can be a decreasing the tidal volume less than 250 millimeters, 250 ml, or a progressive tachypnea more than 30 per minute, and decreasing static compliance, which should be which is less than 30 ml per centimeters of water. I'll just move on to the second topic, sir.
Oh, this is all what you have prepared for this question.
Sir,
The actual wording in the question is modes of weaning from prolonged mechanical ventilation. You are
okay, sir.
saying the criteria for weaning the patient. What you have described, you all
Okay,
would
sir.
need the criteria for when will you decide
Prolonged
to wean the patient. No. Where is the word weaning used other than this concept of or context of mechanical ventilation?
Weaning, decreasing, sir.
No. Where else in medical field we use the word weaning? Are you married?
Yes, sir.
You have children?
Yes, sir.
Okay. So when the mother starts breastfeeding and they want to stop, what do you call that?
Okay, sir. Weaning off from.
Weaning
Okay,
from
sir.
breastfeeding, isn't it? So weaning means
Yes, sir.
gradually decreasing and making them go to the normal pattern. Okay, that is the meaning of weaning. But my question there, always please read the questions properly. In the exams, when the questions are given, you have to sometimes miss the point correctly by not reading the question properly. The question I have worded is modes of weaning from prolonged mechanical ventilation. That means you have to describe each and every
Ventilator modes.
method or mode that is adopted in the ventilator to wean the patient. Okay,
Okay, sir.
that's a very large topic. In fact, I was thinking that whether you will be able to cover both this modes of ventilation as well as golden hour.
Yes, sir. I've actually written on the modes of ventilation, but I thought the question was going to be about the.
No. That means if the question is worded, describe the technique of weaning from the prolonged ventilation, or describe the criteria for weaning from prolonged ventilation, then what you have described is absolutely fine. The prerequisites for weaning a patient. What are all the parameters by which you will decide that patient is now able to breathe on his own spontaneously and doesn't require any assistance. Okay? So some people, in fact, say they are liberating the patient from mechanical ventilation or the assistance of a machine. So instead of saying the word weaning, they are now using the word liberation from mechanical ventilation or a machine-assisted ventilation. So what you have described is the criteria to decide that this patient is not in a requirement of any assisted or mechanical ventilation anymore. And whenever you start or put a patient on a ventilator, our aim is always to take him off the ventilator as early as possible because of the a lot of complications that we can produce. We always try to get him back to the normal natural breathing so that all the complications like barotrauma, volutrauma, reflective trauma, or biotrauma, these are the core trauma that can happen in mechanical ventilation. So we want to avoid that. And we should not make the patient also ventilator dependent. By prolonged ventilation unnecessarily, you make the patient's muscles go into slack mode and they don't attempt properly, and their tidal volume will be inadequate. And you will land up in what is called ventilator extubation failure. where you re-intubate the patient within 48 hours of extubation. Okay? So all these things are given as a prerequisite for weaning. But when they say modes, if you find the word modes in the question, you have to describe how the various modes, like how do you classify the modes of ventilation for weaning purpose?
Sir, controlled and assisted, sir.
It's classified as conventional mode and the newer modes. That is how they are classified. Okay.
Okay, sir.
So in the earlier days, when we were postgraduates and when we were trained in mechanical ventilation with ventilators, we all started with pressure cycle ventilators first, which was Bennett Coleman ventilator, which was purely a pressure cycle ventilator, which means the cycling will get altered or become inspiration to expiration based on the pressure achieved or the pressure set. So once the set pressure is achieved, whether the tidal volume gets delivered or not, the inspiratory cycle will come to a stop and it will switch over to expiratory phase. And this resulted in inadequate tidal volume delivery and also the pressure. Sometimes if the patient is struggling or fighting the ventilator, the mean airway pressure will go up very high and the chances of volume from barotrauma are more in pressure cycle ventilator. So people started switching over to volume cycle ventilator. Even today, when you use your anesthesia ventilator for a GA case, which mode do you prefer for an adult?
Usually volume control ventilation, sir.
Usually you prefer volume control. When will you choose pressure control mode?
If we don't, if the patient is undergoing any laparoscopic surgeries, or if in case we don't want to cause any barotrauma to the patient, we might use pressure control ventilation, sir.
Which category of age group of patients you prefer pressure cycle mode?
Maybe the pediatric patient, sir.
Pediatric patients, we prefer pressure cycle. Adult, we prefer volume cycle. So in volume cycle, as you all know, that until the set tidal volume of say 500 ml or 400 ml, whatever you set is delivered, irrespective of the pressure change, it will try to deliver that entire volume and then only change from inspiratory to expiratory phase. And the machine will do that by prolonging the inspiratory phase if the tidal volume is not delivered within the time that has been set. Okay, so it will have the capacity to alter the IE ratio, which is the timing between the inspiration and the expiration. Okay, so the oldest method when we were all postgraduates and we were taught to mechanically ventilate, what we used to do once we decide that patient has regained sufficient power and he has the strength to breathe on his own, we simply disconnect the patient from the ventilator and attach a T-piece to the endotracheal tube, because most of them will be on an invasive ventilation, not non-invasive like nowadays. So there will be an endotracheal tube and we connect the T-piece with an oxygen supply to the ET tube and observe the patient for 2 hours. And as you say, if the patient is not breathing adequately, we will go in for hypoventilation. He will not maintain the minute ventilation. And gradually, he will develop first hypoxemia, then hypercardia. And the cardiac system will come into support by tachycardia, diaphoresis, altered sensation. All these things will happen. If that is the case, then we will disconnect the piece and again put him back or connect it back to the ventilator, because the ventilator will be kept as a standby close to the patient all the time. So this is called the spontaneous breathing trial with supplemental oxygen supplied through the IST piece. So one of the questions they ask in the practical exams is, what is the use of IST piece apart from as a circuit for anesthetizing pediatric patients? What are the other indications for TPs? One is the weaning process. You use it for supplementing excess oxygen for a spontaneously when you do the SBT, that is spontaneous breathing trials are done. You use the any other indication for using the ISTPs in an adult apart from this ICU weaning purpose? Any historical indication you know of? is not practiced nowadays, but it was one of the old history. If you read, you will know. So in the olden days, when all the monitoring systems were not developed, whenever they did the posterior cranial fossa surgery, the sitting posture, where the neurosurgeons used to operate close to the vital centers in the medulla and pons, they used to attach only the T-piece and allow the patient to breathe spontaneously. Okay? So that at the expiratory end of the T-piece, they used to have a small bit of cotton attached or tape there. And during spontaneous breathing, when the patient is breathing normally, the wick will move forward and backward based on the inspiration and expiration. And whenever the surgeon goes near the respiratory center, the medulla, then there will be an abnormality in the respiratory pattern. Okay. So based on that, they will caution the surgeon. The anesthetist will be watching the movement of that cotton wick, then caution the surgeon that he is very close to the vital centers and he will immediately move away, and they will wait till the respiration becomes normal. This used to happen way back in 70s when we were postgraduates. We used to do that. But now everything has changed. The concept is no more we are using the technique, so it has become obsolete. But the two indications for use of TPG, one is still we are using it as a modified Jackson-Fish circuit, and the first basis is the TPs, and the other use is still we are using it as a supplemental oxygen for spontaneous breathing trials. Now, what is the indication or why pressure support was developed? What is the basis of pressure support ventilation?
Sir,
or PSP?
For any patient who is spontaneously breathing, this ventilator provides an assisted breathe to a preset inspiratory pressure, sir. So that
whenever he is not able to take a breath that adequately, patient who is being trying to be weaned from a mechanical ventilator support, he may not have a normal ventilation with a normal rate immediately, because the disease process is gradually now recovering. So that is another point you have to mention, that the basic underlying lung pathology or whatever indication we have been using for the mechanical ventilation, patient should have had a reasonable recovery from that underlying condition. Then only we always think of weaning the patient from ventilator. So in pressure support, the machine will automatically supply whenever there is an inadequate breath or hypoventilation by the patient. So instead of completely disconnecting him from the ventilator, with the ventilator connected, pressure support will take care of the weaning process. Okay, that is pressure support became very, very popular as a weaning trial or a weaning method when mechanical allowed to breathe on its own. Then, yes, actually before pressure support, we had machines with the SIMV, synchronized intermittent mandatory ventilation, which is the precursor or the first step before the pressure support came in, where the normal tidal volume that is set for assisting the ventilation in the control mode, the same tidal volume will be delivered whenever there is a negative pressure created by the inspiratory effort is less, not adequate, then the machine will supplement that. Whereas in pressure support, it will develop, it will support the pressure part of it and not the volume part of it, because it will make the patient breathe on his own by developing more negative pressure. Whereas SIMV will try to deliver the entire volume that you have been set for, like 400 or 500, whatever you set. For every deficient breath, it will supply the whole thing. So that is the change from SIMV to PSP. So SIMV produced a lot of paratrauma because it is delivering larger than what is required. Just only assist and give a partial volume and not the entire volume that is required whenever the patient's attempts are inadequate. Okay. So now these are the three conventional modes of weaning which were used. Then later on, they have modified the same pressure support into various things like volume, stewed ventilation, excessive pressure release ventilation, and so there are so many newer modes which are all the basic principle used is to use the support of or modify the same pressure support into various categories. And this is possible because earlier days the ventilators were mechanically delivering whatever parameters you set on the ventilator. They were not getting a feedback from the patient except the inspiratory atom. They were not getting the other parameters like mean airway pressure or compliance and resistance. All these things were not fed into the machine. But now we have developed what is called a closed loop system of ventilation, where the patient's parameters like airway pressure, resistance, compliance, secretions, anything which is not normal will all be fed back into the machine. So machine will be able to adjust for each and every change that is happening in the patient. So it is able to modify and deliver the set tidal volume or the required tidal volume at a very safe pressure. That is the basis of the newer modes of ventilation. It is possible because of the feedback that the machine is getting by what is called the closed loop system of ventilation. Okay? And this can also be classified as protocolized and non-protocolized ventilation, where you have a set of protocols to follow and then you set the patient the parameters in the ventilator and try to wean the patient. In non-protocolized, which is much useful in patients who have very good power, like for example, if you electively ventilate a post-operative patient, you are quite sure that within 24 hours or a maximum 36 hours, patient will be strong enough to breathe on his own because there is no underlying lung pathology. You are ventilating him because you would have had a gross hemodynamics. For example, a liver transplant patient. You don't extubate him on the table unless everything went on well and the hemodynamically every parameter was all right. So post-op surgical patients will usually require ventilation at the most for 24 to 48 hours. Whereas the critical care and ICU patients who have some underlying lung pathology, until they require from them, for example, a pneumonia patient who is on a ventilator, it may take at least 7 days or 5 days to recover till the underlying pathology completely resolves. And so that is the difference between the modes that you are using. For shorter duration, more stronger patients who are able to develop or come back to normal ventilation, you use certain strategies. For patients who have reduced power, muscle weakness, or underlying lung pathology, which affects both the oxygenation or some cardiovascular events which is not supporting the cardiac output and tissue oxygenation, these patients will take a longer time. So for them, you have to modify it in such a way that you neither over deliver the volume or give more pressure. So for that, the machine has to get the feedback from the patient's parameters and make a dynamic adjustment. For example, the machine has to know the reduction for each and every breath. Then only it can augment or supplement the required volume. The earlier machines which were used, they were taking an average of say 5 breaths or 10 breaths. Even when a patient is hypoventilating, they will not supplement each and every breath based on the volume or the power that the patient is able to generate. So that much of advancements have come. That is why they are called the newer modes of ventilation. Sometimes they ask this question as simple, describe the newer modes of ventilation. It may not be for weaning. It may be for even maintenance of ventilation or initiation of ventilation. So all these modes you have to describe in the answer if this is given. Okay. So if you are prepared, you can read that. Otherwise, I will show the PPT and share that.
Yes, sir.
If you're not ready with that answer,
also,
you can. Pardon?
Also, I thought that would be elaborate, so I just cut short it, sir. I've already prepared for that
No,
too.
no, it is not elaborate. You have to write all that in your theory,
Okay, sir.
and then only you will get the marks.
Okay, sir.
Especially when they mention the word modes of ventilation, you have to describe all the modes.
Okay, sir.
Okay, right.
So, to start with the modes of weaning, the TP trial, where the mechanism is the patient to an endotracheal tube without a ventilator support. The indication is going to be simple and effective for short weaning trials. The pros for this TPs is it mimics the actual spontaneous breathing and evaluates the true readiness for extubation. And the cons are there is no ventilatory support, may be tiring for the weak patients. The second option is the CPAP, which is the continuous positive airway pressure. Here the mechanism is it provides continuous positive pressure to keep the alveoli open. The patient can breathe spontaneously. The indication is it is used in patients with chronic lung disease or atelectasis risk. And the pros of this is going to be it reduces the work of breathing, versus TPs, maintenance the alveolar recruitment. And the cons is the no ventilatory assistance for hyperventilation will be provided. The third one is the pressure support ventilation, where the mechanism is spontaneous breaths are assisted with the preset inspiratory pressure to overcome the tube resistance and reduce the work of breathing. Here, the indication is most common mode of prolonged weaning. This is the most common mode, and the pros are going to be we can adjust the support and can titrate to gradually reduce the pressure, which can help at the progressive weaning. The cons are the we may overestimate the patient's strength if the support is too high. The fourth option is SIMV, synchronized intermittent mandatory ventilation. Here, the mechanism is to provide the mandatory breaths synchronized with the patient's effort. The patient can breathe spontaneously between mandatory breaths, and the weaning is going to be gradually decrease the mandatory rate, allowing more spontaneous breaths in these patients. The pros are gradual transition and reduced risk of fatigue, but the cons is going to be it may prolong the weaning compared to the PSV or TP's modes. There are adaptive or advanced modes known as the automatic tube compensation, where it compensates for the endotracheal tube resistance during spontaneous breaths. There is proportional assist ventilation, which provides assistance proportional to the patient's effort, and neurally assisted ventilatory assist, which is also called as NAVA, where it uses diaphragm electrical activity to adjust to the support. And these are the advantages for this mode. It is a tailored support and usually more often comfortable and efficient, but the cons are going to be these requires more advanced ventilators and monitoring.
I'll just show my presentation on that before
Yes.
we go to the next topic of golden hour. So the question here it is worded as modes of weaning from prolonged mechanical ventilation. I have omitted that prolonged. So the question is worded like this. So, but for knowledge sake, I have initially added a few slides or few points. So weaning from mechanical ventilation is defined as a systematic way of removing the patient from the support of ventilation. Readiness of spontaneous breathing trial, that is weaning, the patient has to, the cause for the respiratory failure has to improve. That is the first and foremost criteria, whether it is a pulmonary problem or whether it is a cardiac problem or whatever indication you have put the patient on the mechanical support, that cost, underlying cost should have resolved or it should have improved. And all the other parameters you described are all the reflections of how the patient's ventilatory power is there. For example, if we take the PaO to FiO2 ratio, the saturation, if the saturation is more than 90 and if all these parameters are there, that indicates that patient is adequately having a reasonable good effort and he will be able to maintain. And whenever the oxygenation and the CO2 elimination are good, the pH will be maintained within the normal value, and you can slide acidotic value up to 7.25. You can agree because the normal value is between 7.35 and 7.45. more than 7.25. That's mild acidosis is acceptable because the acidosis will help. What will happen to the OTC curve in acidosis? Are you hearing me?
Yes, sir.
What will be the response of oxygen dissociation curve to acidosis? Will it offload the oxygen or retain the oxygen?
Sir, offload the oxygen, sir.
It will offload the oxygen. Okay, so that is the reason why they are able to, they are accepting a mild acidosis, doesn't matter. And patient should have a hemodynamic stability. That is very, very important. He should not be having a hypotension or requiring 3 or 4 vasopressors to maintain the BP. That unstable hemodynamic status is not a good indicator to attempt weaning. So hemodynamic stability and resolution of the pathology, which was the indication for ventilator, are two most important criteria, and these parameters are only an objective evidence whether the patient is breathing normally or not. And whenever he is taking a normal inspiration, the negative pressure he creates should be sufficient to initiate the breath. Because when you put a patient on mechanical ventilator, we are completely traversing the normal physiology. Because in normal physiology, the inspiratory effort should create a negative intrathoracic pressure. But once you intubate or put a patient on mechanical ventilatory support, we digress from this and we immediately switch over to positive pressure both during inspiration and expiration. So when the spontaneous effort comes, this inspiratory effort is the most important indicator to assess whether the patient is be able to take a adequate breath or not by the negative pressure that is shown in the ventilator. And patient should not be either hypothermic or hyperthermic, and he should have a reasonable hemoglobin to have the oxygen carrying capacity, and the alertness and mental state, which is a reflection of the oxygen supply to the central nervous system, is also a very important clinical parameter to decide whether the patient is fit enough to be weaned from the mechanical ventilation. So the two important things you have to remember are resolution of the underlying pathology, hemodynamic stability, and because patient is now spontaneously attempting and he is able to maintain these parameters, he should have a normal central nervous system function in the form of consciousness and orientation, and heterogenically he should not have been in either hypothermia or hyperthermia. And if the disease has caused an anemia, the hemoglobin should not be less than 7 grams, because that will affect the, even if his respiratory attempts are good, he will not be able to deliver the oxygen to the tissues because of the low hemoglobin. Okay? And to remember that this is the mnemonic that you can remember: A, B, C, D, E, F, G, H, I. Aim of the ventilation met, and the patient is alert and afebrile. If all these things are criteria. Breathing indices, that is the parameters that we use. Breathing indices are acceptable with no distress. C, circulation and hemodynamic stable. D, drugs, no sedative or neuromuscular blocking agent drugs are being administered. That is also a very important square. And E, electrolytes, sodium, potassium are all normal. F, fluid status, no dehydration or overhydration. Glucose, euglycemia, and H, patient having no hallucination or delirium and cooperative, and no impending procedures or transfers are required. So if these things are all met with, then the patient is fit for weaning. And so the common modes of ventilation, you can classify them into conventional modes used, like pressure support, continuous positive airway pressure, synchronized intermittent mandatory ventilation. And the advanced modes are the newer modes that uses volume support, volume assured pressure support, mandatory minute ventilation, airway pressure release ventilation, and automatic tube compensation. So these are all some of the advanced modes. Each one you can just write 1 or 2 lines and that will be enough. Now, classification of criteria, what you said is again another part of knowledge, as well as if the wording of the question is describe the mode of weaning a patient from ventilator, that means you have to write all the criteria and as well as the modes that you will be using. Whereas if they say modes of ventilation for weaning, then you can straight away go to the various modes. So the other way of describing the eligibility for weaning are clinical criteria, where resolution of this is something like a repetition of what I have shown in the earlier slide, and so no harm in learning it again and again. Resolution of acute phase, adequate cough, absence of excessive secretion. These are all clinically you can judge all these things. Ventilator criteria: patient, if he is allowed to breathe spontaneously, is for 20 to 30 minutes. He should not become tired. He should not hyperventilate. He should not develop a retention of carbon dioxide. And he should be able to have a vital capacity of more than 10 ml. And tidal volume, it should be more than 5 ml. Measure it with the spirometer. And his respiratory rate clinically should not be less than 35. He should not be tachypneic. And the RSBTA, that is all of you, those who have worked during the COVID time, all of you would have known that one of the criteria that was advocated for weaning a patient from mechanical ventilator reserve port is the rapid shallow breathing index, which is calculated by the frequency divided by the tachy volume, which is described as number of breaths per minute per liter, and it should be less than 100. And minute ventilation less than 10 liters with satisfactory arterial blood gas analysis. So these are the ventilatory criteria. And oxygenation criteria: patients' PaO2 should be more than 60 with a FiO2 of 0.4, that is 40% oxygen, without any assistance of PEEP. And if he is giving PEEP, then it should be more than 100 with an FiO2 of 0.4. And the peripheral arterial saturation should be more than 90 with an FiO2 of again 40%. And PaO2 FiO2 ratio should be more than 150. So this was one of the important criteria that was used because COVID produced a picture like ARDS, and that takes a longer time to resolve compared to your other indications for ventilation. And the shunt fraction, PH-QT ratio should be less than 20. And the alveolar arterial oxygen difference should be less than 50 ml at an FiO2 of 100%. Now, pulmonary reserve and measurements. Pulmonary reserve, vital capacity less than more than 10 ml, maximum inspiratory pressure more than 30 centimeters. And measurements, what you can do is the static compliance more than 30 ml per centimeters of water. Airway resistance stable or improving. VD/VT ratio less than 60% in intubated patients. Now, protocolized versus non-protocolized weaning. So, weaning protocols consist mainly of three parts. One is the objective criteria to judge the readiness to wean the patient and decrease the support gradually, and criteria to assess the readiness for extubation. So, first you remove the patient or disconnect the patient from ventilator, and immediately we don't extubate the patient unless all the parameters are very, very good and the weaning trial has gone on for at least minimum 2 hours and patient is stable. Normally, we don't extubate all the patients immediately. So once the weaning, the respiratory parameters are maintained well for at least a minimum of 2 hours, then you think of extubating the patient if you have invasively put in a endotracheal tube. So the use of protocols led to shorter duration of mechanical ventilation, no extra side effects with a moderate quality of results. But the variations in type of protocols used, which especially for ICU patients, make it difficult to recommend a certain protocol for general use. So each institution forms their own protocol, and as of today, there is no generalized protocol which should be uniformly accepted and practiced in for all these institutions. Now, automated versus non-automated weaning. Earlier we used to mechanically adjust all the parameters, which is called non-automated. So every time you want to switch over, do the SAME especially, you first start with 12 to 14 breaths assisted per minute, depending upon the patient's effort. Then you gradually reduce it to every hour, you reduce it to say from 12 to 10, 10 to 8, 8 to 6, like that. And when the support needed is only 1 to 2 breaths, you feel that you decide that the patient is adequately breathing and you can disconnect and extubate the patient. So automated uses closed loop systems. That's what I told you. It can measure the dynamic changes that happen in the patient, automatically adjust the level of support given to the patient. Compared to usual protocolized system, automated system showed shorter duration of weaning and shorter total duration of mechanical ventilation. And whereas non-automated, it's an older method where we have to adjust the parameters every few hours, depending by observing the clinical as well as the objective evidences of oxygenation and ventilation. So this is again another new modes where the earlier slide you won't find this adaptive support ventilation, which is also one of the newer modes. And these are the various modes and their how it works or patient work adjusted by that is the SAME pressure support, a combination of SAME and pressure support, volume assisted pressure support. So all these things are the various modes just for the numbering. So looking at the individual modes of ventilation, this is started with a pressure of 5 to 15 centimeters to augment the spontaneous ventilation until the VT and RR settles down to normal rate. So whenever the patient is hypoventilating, this will automatically give extra pressure to deliver the tidal volume. And the advantage here, the patient need not be disconnected from the ventilator. That is the biggest, because once you put the patient on PS mode, all of you know, even some of the anesthesia ventilators have this mode, so you don't have to. At the end of the surgery, when the patient is breathing spontaneously, you just switch over to PS mode, and the patient will automatically be taken care of by his respiratory attempts will be augmented whenever there is a hypoventilation. And the PS pressure can be gradually extubated, and we can straight away extubate the patient. That is another advantage of pressure support. We don't have to disconnect and wait. Once the patient is able to tolerate the lowest pressure that is supplied by the machine, that means he is having a full power and adequate tidal volume generated on his own, so he can straight away extubate the patient. Now SIME is an older method compared to PS, where it is the conventional method used after the TPs. So as I told you, the oldest method of weaning was TPs supplementation. So you don't hurriedly extubate the patient once you feel he is having a normal spontaneous respiration. You connect him to TPs, wait for some time. Then if the parameters are okay, patient is not getting agitated, he is not sweating, he is not developing tachycardia, he is not having tachypnea, that means he is normal. So we used to extubate. But SAMV is another method of supplementing whenever there is a hypo attempt, but it causes a greater work of breathing, and compared to assist control mode or the pressure support also, it helps in the negative pressure created by the patient normally. So as I told, once you put the patient on mechanical ventilation, we are completely traversing the normal physiology. The inspirated negative pressure is abolished and it becomes all positive pressure. So once patient starts breathing normally, the inspiratory attempt on his own, the negative pressure created will help in the venous return to the heart and improve cardiac output. Now the SAMV mode can produce three types of breathing pattern. One is the patient initiated assisted ventilation. So whenever a patient takes a inspiratory attempt, but that is not sufficient, then the machine will automatically deliver the required tidal volume and complete that breath. This is called the patient initiated assisted ventilation. Then At times when there is no attempt at all, in between breathing as a pattern, he is not making a negative attempt at all. For example, you have been sedating the patient or paralyzing the patient. Now patient is regaining his spontaneous slowly, and he is still under partial effect of the sedation, and on and off he goes into an apneic spell. At the time, based on the time gap between the breath, it will automatically deliver the entire tidal volume, and it will be like a controlled ventilation where it will deliver the breath and there is no negative atomic pressure. Then it will allow the patient to breathe spontaneously. If his negative pressure generation is good and his inspiratory capacity is good, then it will not interfere. It will allow the patient to breathe spontaneously. So all these three patterns, assisted ventilation or complete controlled ventilation or total spontaneous ventilation, all are possible with this SAMV method of ventilation. And but you should not use the SAMV as a standalone method, especially when you are initiating the mechanical ventilation in a patient. This should be used only as a supportive method and not as a standalone method. So gradually reduce the SME frequency by 1 to 3 breaths, monitoring the SpO2, arterial blood gas. That is, initially you give a larger support number. That is, you set a assisted ventilation, gradually reduce it by 2 breaths every hour. And once the patient is tolerating between 1 to 3 breaths support, then he may be, you watch the SpO2 and the ABG. If they are satisfactory, that means he will be ready to be disconnected from the ventilator and he can be extubated also. The third method is adaptive support ventilation, which is used not only for weaning, but it can be used right from the beginning of initiating the ventilation, maintaining and weaning. And the Galileo ventilator has this particular mode of ventilation. And the parameters you have to set for using this mode is you must enter the patient's weight, with which the machine itself will calculate the tidal volume. You have to set the peak, pressure limit, volume control, everything. And normally it will require 100 ml per kg in adult, 200 ml per kg in children. And the mode does breath to breath assessment. That is the important difference between the earlier modes, where they used to take the average of the previous 5 or 10 breaths. Here, dynamically, it will measure the every breath and then constantly adjust the pressure support when inadequate mandatory breaths are delivered to augment the tidal volume. So, compared to PS, this is a newer mode of ventilation, which is more popular in not only maintaining but also in the weaning. And so it will help in both the PS spontaneous as well as SAMV spontaneous or inadequate. Then the fourth method is volume assisted pressure support. It is a pressure triggered mode, and variable flow and volume ventilation will happen, and it will definitely deliver the tidal volume that is required. And if the TV is not achieved by the patient, it will prolong the inspiratory time till the set volume gets delivered. So it assures the volume. So that is the importance of that. And the volume delivery is based on the individual breath. So here also each and every breath is analyzed, and the machine will decide whether he requires an assistance or not. And it is useful in patients who have good power and have adequate spontaneous effort. And it functions as a more as a backup mode of ventilation than supportive ventilation. And it only increases the pressure, but it cannot lower the pressure. So whenever there is a dyssynchrony, then there is a chance of raised airway pressure in these cases, which can be very harmful. Now the sixth mode or fifth mode is volume support ventilation, allows spontaneous breathing, and the preset minute ventilation is achieved by the patient. If the patient is able to completely generate the minute ventilation on his own, this allows complete spontaneous breathing without any interruption. But if the patient fails to deliver the they use the minute volume at the very lowest pressures. So that is one disadvantage is that this mode is set to the tidal volume and respiratory rate, which should be close to spontaneous efforts of the patient. So whenever you start weaning, patient may not immediately come back to the normal respiratory rate of 16 to 20. He may initially be having a respiratory rate of 30 or 35, and gradually it will come back to normal. So during that time, setting a tidal volume and the rate which is physiologically normal between 16 and 20 will clash with the patient's spontaneous effort and will make it like a fighting the ventilator. So the initial setting in this volume support ventilation should be close to the spontaneous effort. So you can clinically count the respiratory rate and keep the assisted ventilation at that rate. And then as the parameters, as the patient respiratory rate comes down and the tidal volume improves, you can also gradually reduce the setting to adjust and match his normal respiratory pattern. And this is used in weaning patients with limited breathing but intact respiratory drive. And these patients, especially those who are recovering from acute lung injury, like pneumonia or blood transfusion lung injury, whatever form of lung injury is there, those patients, this volume support is very useful because it will not create a very high pressure. And it generates the low peak inspiratory pressure, less chances of barotrauma. That is now the main advantage, especially in patients recovering from an acute lung injury. And it also causes less CVS interference, and it doesn't require much sedation because it does not cause any raised airway pressure. It doesn't require sedation, and it causes improved gas distribution. So this is one of the good methods to use. Then automatic tube compensation. Sometimes this is asked as a short note question also. It's a feature on mechanical ventilators which mainly used for reduce the work of breathing. All of you know that when you intubate a patient with a tracheal tube, the flow, how does it take place? It takes place because of the difference in the pressure at the proximal and distal end. So whenever the patient's proximal pressure is high, the air is or the gases are pushed down towards the respiratory tract. And the distal end will be having a lower pressure, so there is a forward flow which always takes place. And if this pressure difference is very high by putting a very small tube or a secretion causing a blockage, then the patient has to do more physical work to take an inspirator and inhale the gases. So that will cost more. That is why we want to always intubate with the maximum size tube without causing any pressure necrosis or injury in the trachea to the patient, so that the resistance will be very low and that will reduce the work of breathing. So the automatic tube compensation works by this mechanism. It dynamically adjusts positive pressure during inspiration and negative pressure during expiration. And the patient will feel as though he is breathing without any artificial airway in his throat. So that is the advantage of this automatic tube compensation. And as pressure support may under support the work of breathing, early inspiratory phase, during which time this work of breathing will increase, the automatic tube compensation helps in that condition. And TS may not help adequately during various stages, like when the patient is awake, asleep, or agitated. During these phases, the difference in the pressure gradient between the proximal and distal will vary. When the patient is awake, he will be more anxious and he will be trying to breathe with more difficulty. And when he is asleep, the stimulus is less and the pressure difference will come down. So pressure support may not be used to adjust all these changes. Whereas the ATC, this mechanism, automatic tube compensation, will help and automatically adjust the difference in the pressure. And the next method is the proportional assist ventilation, which is also a very new mode and very good mode for mechanical ventilation that provides pressure support which is proportional to patient's inspiratory effort. So depending upon his inspiratory negative pressure created, it will decide whether to augment more volume or restrict the volume and improve patient ventilator synchrony. It will prevent the so-called ventilator fighting because unnecessary increased volume or pressure during inspiration will make it uncomfortable for the patient. Similarly, when the patient is breathing out, any resistance or increased pressure which will not allow the exhaled air to go out, that will also make the patient uncomfortable. So the beauty or good ventilation should be, it should adjust to the patient's own pressure and the volume capacity that is inhaling without making him feel the excess pressure or excess volume. Similarly, during exhalation, it should not offer any resistance. It should allow the exhaled air to go freely and completely without any narrowing or restriction. That is the thing that has to be done, and this is done by the proportionate assist ventilation. And then it is dynamically adjusted to every breath at the level. So to match the desired level of support, the patient's instantaneous demand. So all these modern ventilators are new modes because of the closed loop system. They are able to perceive each and every attempt of the patient and decide whether to increase the pressure or volume and deliver it according to the need. And it's not properly adjusted. This proportional assist ventilation needs a proper setting, and if it is not done, it could lead to over resistance, or sometimes when the patient is hypoventilating, it may not give adequate ventilation also. So it requires a little bit of learning curve on the part of the person using this mode. And once you know how to set it properly, it will be a beautiful mode to assist the patient without any difficulty. Then the next mode is volume support ventilation, which is a spontaneous mode and delivers a serial tidal volume by automatically adjusting the pressure support. And the patient initiates every breath. That is, whenever he is taking a negative pressure, ventilator responds by increasing or decreasing the pressure and also ensures the tidal volume is delivered accordingly. And it's purely a spontaneous mode, does not include backup or mandatory breath. And separate backup ventilator must be set for patients who may not become apneic in between. As I told, when a patient is getting weaned off from sedation during mechanical ventilation, sometimes they may suddenly become apneic for a few seconds. So in that situation, the machine should be able to sense that and immediately supply the required. The other mode is volume assured pressure support. This is again a mechanical mode that automatically adjusts pressure and consistently deliver the preset tidal volume. And it ensures that increasing pressure support if the volume is too low or decreasing the patient's condition improving, all that can be automatically done. Then the other mode is mandatory minimum minute ventilation, which is a mode of mechanical ventilation, provides minimum minute volume and allowing spontaneous breathing without any hindrance. And it's again a closed loop system, monitoring the patient's breathing and delivers mandatory breaths at set pressure and tidal volume. Only if the patient's spontaneous breathing falls below a clinical preset volume or minute pressure in the ventilator, it will immediately try to help and reach the target. And again, proper settings are very crucial. Otherwise, it will behave like the earlier mode I told you. It may overventilate or underventilate. And close monitoring is very mandatory for all these modes. And to avoid all these problems, they have now introduced what is called the airway pressure release ventilation, which is a mode used a high continuous positive airway pressure for most of the time, but for a brief time, release the to lower pressure so that the problem of barotrauma is taken care of. So the high pressure period helps to keep the alveoli open and recruits lung volume. So it is more to do the recruitment maneuvers, especially in athletic reticulum, and the release phase allows for exhalation and effective CO2 removal. So CO2 retention will not happen in this mode. But the risk of lung injury, autopeep, and hemodynamic compromise, because the high pressure is used, that can happen, and it also can increase secretion or lack of standardized setting, or the disadvantage of this particular mode of ventilation. And lastly, I think the continuous positive airway pressure is also one of the non-invasive methods where if the patient has already been extubated and you need to wean him in extubated mode, then you can use this CPAP. And nowadays, the conscious patient with pulmonary edema, like the cardiac failure patient, we try to manage the pulmonary edema with CPAP rather than intubation and invasive ventilation. So this is used for weaning also. It is a non-invasive method, reduces the mean intrathoracic pressure, and the beneficial effects are it will improve both the right and left ventricular performance because the inspiratory negative phase will help the venous return and fill the right ventricle, and the pumping of the right ventricle will fill the left ventricle, and so both the right ventricle and left ventricle performance will improve. And it will also reduce the work of breathing by the pressure that is delivered during inspiration. And it you can gradually reduce the support and by decreasing not only the pressure but also the FiO2 and PEEP while monitoring the parameters like oxygenation, hemodynamic stability, and work of breathing. Okay, so this is how we thought we will have to answer this particular question on the modes of ventilation while weaning a patient from mechanical ventilation. Okay, so don't